We are now starting the discussion on irritable bowel disease. What is irritable bowel disease? Irritable bowel disease is a functional disorder of GIT which is caused due to stress, presenting clinically with abdominal pain and impaired altered bowel habits. Please note there is absence of structural, infective, and biochemical abnormalities in irritable bowel disease. So, irritable bowel disease is a functional disorder of GIT caused by stress, which presents with abdominal pain and altered bowel habits in the absence of structural, infective, and bowel biochemical abnormalities. What is the etiopathophysiology of this condition, irritable bowel disease? The pathophysiology of this condition is not well established, but we know some things that we will discuss now. The main causative factor is stress, which causes the visceral hypersensitivity of the GIT due to gut-brain axis impairment. Please note, in 80% of patients with irritable bowel disease, we have associated anxiety, depression, and neurosis. So, stress has been strongly associated with irritable bowel disease. I told that due to impaired gut-brain axis, there is visceral hypersensitivity, meaning the GIT is hypersensitive to gas accumulation and distension, causing pain, abdominal pain. Why? Because this visceral hypersensitivity causes the activity of vanilloid channels, which causes the release of substance P and other substances, which causes visceral pain. Along with this, the patients have increased activity of cingulate cortex, cingulate gyrus of the cortex. Due to this area is responsible for emotional processing of the pain. Due to this increased activity, the patient have pain due to vanilloid channels opening activity, increased activity of vanilloid channels. Along with that, they have increased perception of pain due to increased activity of cingulate cortex. Along with abdominal pain, we mentioned the patient have bowel habits, impaired bowel habits because of increased number of enterochromaffin cells seen in these patients. Increased number of enterochromaffin cells is associated with increased release of serotonin, which is a motility causing agent. It increases the GI motility. Due to that, the patient have diarrhea. And also, the colonic motor potential may be increased or decreased. It is increased. If colonic motor potential is increased, the patient presents with diarrhea. If colonic motor potential is decreased, the patient presents with constipation. So we saw the reasons for abdominal pain and altered bowel habits seen in case of irritable bowel disease. These all factors leads to rectal hypersensitivity, meaning the rectum is hypersensitive, whereas small amount of stool makes the person to make the rectum hypersensitive, and the patient gets the urge to defecate. So the patient will have small volume stools as one of the presentation. What are the clinical manifestations seen in these irritable bowel disease patients? Irritable bowel disease is most commonly seen in less than 45 years of age due to more stress less than 45 years. It doesn't mean that the patient doesn't have stress after 45 years. Still, it is more common less than 45 years of age. It is more common in females compared to males in the ratio of 3:1. The most common clinical symptom with which the patient presents to us is abdominal pain. Abdominal pain is lower abdominal pain, which is precipitated by stressors like poor sleep, emotional stress, menstruation, etc. Due to these stressor events, the patient will have lower abdominal pain, and also characteristically, following passage of stools, the patient will be relieved of abdominal pain. Now, this is the most common clinical findings, that is abdominal pain, lower abdominal pain. The most consistent clinical finding is altered bowel habits. The patient may have diarrhea predominant irritable bowel disease or constipation predominant irritable bowel disease, or the patient can also have a mixed type of irritable bowel disease. In diarrhea predominant one, the patient will have large bowel diarrhea, that is passage of small volume stools with mucus along with tenesmus, and passage of small volume stools, passage of small volume stools, and the patient will have tenesmus in case of diarrhea predominant IBD. In constipation predominant IBD, the patient present to us clinically with constipation, that is non-passage of stools. These are the two main symptoms that is associated with irritable bowel disease. Some patients also complaints of increased belching and flatulence, heartburn, and vomiting, nausea. This is about the clinical manifestations of irritable bowel disease. Now, what are the investigation findings in irritable bowel disease? Please note, irritable bowel disease is a clinical diagnosis. The diagnosis criteria of which I'll mention shortly. We'll do the investigation to rule out other diseases which may present with these symptoms. We do stool examination to rule out parasitic infections. We do sigmoidoscopy and barium enema study to rule out inflammatory bowel disease. The sigmoidoscopy will be normal, barium enema study will be normal in case of IBD, and stool examination findings will also be normal in case of irritable bowel disease. The diagnostic criteria which we have for irritable bowel disease is Rome-4 diagnostic criteria. It tells that if the patient has recurrent lower abdominal pain with at least one episode per week for last 3 months, along with more than or equal to 2 of these 3 criteria, that is related to defecation, meaning the pain improves on defecation, increase frequency of stools or alters frequency of stools, and impaired appearance of the stool, that is impaired form of the stool. The stool may be lumpy, hard in case of constipation, and loose, watery in case of diarrhea predominant IBD. Along with this abdominal pain, if the patient has more than or equal to 2 of these 3 symptoms, the patient is told to have irritable bowel disease. Now, how do we treat these patients? 70% of patients are cured on lifestyle modifications. Mainly, we have FODMAP's diet, reduced intake of FODMAP's food, that is fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. We should reduce the intake of these foods. These foods will cause gas accumulation and distension, which is the reason for visceral hypersensitivity and secondary symptoms. So, decrease the intake of FODMAP food. Those are foods like fruits like banana, apple, mango, decrease their intake. And then cauliflower, onion, carrots, the patient should not consume. We also have so many lists of items which comes out of FODMAPs. I request you to go through that list once. Along with this reduced intake of FODMAPs items, the patient should increase walking or he should perform regular exercise. This lifestyle modification helps in 70% of patients. If the patient is not improving on lifestyle modification, we go on for drug therapy. In diarrhea predominant one, we can give loperamide, that is opioid agonist, which the patient will improve on giving loperamide. It causes loperamide will reduce the bowel motility, thereby helping in treating diarrhea. If the patient has constipation predominant one, we'll give stool bulking agents like psyllium husk or methyl cellulose. If the patient is not improving on this, we can give lubiprostone, which is a calcium channel activator, which causes passive diffusion of water and sodium, thereby increasing stool bulk and relieving constipation. We can try these agents in these patients with constipation predominant IBD. If the patient doesn't see any improvement in pain on giving these agents, we can try antispasmodic agents like dicyclomine to relieve abdominal pain. If the patient is resistant to all these drug therapy, At the last, we can give tricyclic antidepressants like amitriptyline. We all know that it's a condition which is associated with psychiatric condition 80%. So we can try amitriptyline, which is helpful in these patients. To summarize, irritable bowel disease is a functional disease caused by stress, presenting with abdominal pain and altered bowel habit in the absence of structural, infective, and biochemical abnormality. The pathophysiology is the stress causes visceral hypersensitivity, which causes pain due to vanilloid channels activation, increased perception due to increased activity of cingulate cortex, and altered bowel habits due to increased serotonin and increased or decreased colonic motor potential. And also, we have rectal hypersensitivity, which causes small volume stools in these patients. The clinical manifestation, most common one is abdominal pain, which is characteristically lower abdominal pain, which is precipitated by stress and relieved on defecation. We have most consistent sign as altered bowel habits, which can be diarrhea predominant and constipation predominant or mixed. Some patients also complaints of heartburn, increased belching, flatulence, vomiting, and nausea. Investigation findings on investigation, stool examination, sigmoidoscopy, Berry enema study is normal. The diagnostic criteria, we have Rome-4 diagnostic criteria, wherein which the patient should have recurrent abdominal pain at least 1 episode per week for past 3 months. Along with that, the patient should have more than or equal to 2 of these following symptoms that are related to defecation, increase or decrease in frequency of stools, and alteration in the appearance of stool. The treatment, we saw 70% of the patient benefits by lifestyle modification, like reducing the intake of FODMAPs items and increasing walking or regular exercise. In remaining 30% of patients with diarrhea, we give loperamide. With constipation predominant, we give stool bulking agents like psyllium husk, methylcellulose, or lubiprostone. The patient have associated abdominal pain, we'll give antispasmodic drugs like dicyclomine. If the patient is resistant for these drug therapy, we can give tricyclic antidepressants like amitriptyline. Thank you for listening.